are in listen-only mode.
Hello, everybody. This is Marcy Ravitch, and I'm the director of the Massachusetts Child Psychiatry Access Project. We want to welcome you to our first of our monthly clinical conversations that we're holding on a variety of topics of interest to primary care providers and behavioral health care providers. Today, we are thrilled to have with us Dr. Sharon Levy, who is the director of the Adolescent Substance Abuse Program at Boston Children's Hospital and a nationally recognized expert in substance abuse among adolescents. A few things I just want to mention. We're going to be recording this broadcast, and it will be available shortly after the webinar on the MCPAP website, which is www.mcpap.org. You will also receive a brief survey following the webinar, and we'd really appreciate if you could complete that. It will pop up automatically, and when you're done, it will get sent to us automatically, and it is anonymous. Want to let you know that the Expert Toolkit with the S2BI screening tool is available from the DPH Clearinghouse. It is also available to download off the MCPAP website. The URL for the DPH Clearinghouse is at the end of the presentation, so that will be available to you. And we just want to remind you that you're on mute during the presentation, and then we'll be taking questions afterward, and we'll unmute you. In the interim, you can type your questions into the question box, and we'll have those to respond to as soon as Sharon's done with the presentation. Thank you.
So Marcy, thank you for inviting me today to present this webinar on screening, brief intervention, and referral to treatment, or SBIRT, in adolescent primary care. We're having a technical difficulty advancing the slides. So I want to start with a brief case. This is Trevor. He's a healthy 17-year-old boy. He's a B+ student and a 2-sport varsity athlete, and he comes in for primary care. He reports occasional drinking with friends on weekends, but he denies ever using illicit drugs. And his primary care provider assesses him as low risk since his drinking is occasional and it's social. And he seems to be doing well in school and sports. 1 week after the appointment, Trevor attends a party with friends and he has a couple of beers. While driving home, his car slams into a tree and Trevor is pronounced dead at the scene with a blood alcohol level on autopsy of 0.24. So I'm sorry to start with such a difficult case, but I use it to illustrate a couple of points. One thing is that there is no safe level of drinking for adolescents. And while drinking by older teens is common, and even if all of us screen and do perfect brief interventions, we will not be able to stop all of it. At the same time, failing to give clear advice not to drink is really a missed opportunity in primary care, and really that's going to be the focus of the presentation today. And then finally, I would say that the case vignette did not provide enough information to accurately assess Trevor's risk. This slide is from the toolbook. It's a screenshot of page 7, just reminding us that the American Academy of Pediatrics recommends abstinence as the best health advice for teens. And the AAP also advises parents to set a clear no-use policy around alcohol, tobacco, and other drug use. So why is abstinence so important in the teen years? Because teens are more susceptible to both acute and chronic problems associated with alcohol and drug use, even compared to adults. This graph shows us that at every blood alcohol concentration, a teen is at greater risk of being involved in a motor vehicle crash compared to older drivers. This slide was from a recent report that shows us the percent of college students that had alcohol involvement at the time of a sexual assault, and you can see it's over half of women and nearly 3/4 of male students. If we put these together and say where either the male or the female had alcohol involvement, that number goes up to nearly 100%. And in addition to all of the acute consequences of alcohol use, which we're very familiar with from the newspapers and all the stories we hear coming in from our patients, it's also true that the developing adolescent brain is particularly vulnerable to the toxic effects of both alcohol and other substances. It's been shown that early initiation of alcohol and marijuana are associated with much higher risk of developing addiction or substance use disorder. So in this graph, we see that teens who start drinking before their 13th birthday are 5 times more likely to develop an alcohol use disorder compared to those who delay initiation until age 21. So this graph is showing us the good news about screening in primary care pediatrics. So these bars come from 3 reports, 3 different data sets, each of which asked pediatricians, do you screen adolescents for alcohol use? The first bar shows that in 1997, fewer than 50% of respondents said that they were screening adolescents routinely. By 2007, we did a survey here of Massachusetts pediatricians, and we found that 86%, nearly double, said that they were screening for alcohol use routinely, and by 2013, a national survey found similar numbers. And I think this data is really showing us that the culture of pediatrics has changed. In the mid-1990s, people who were particularly interested in adolescents, perhaps, or focused on substance use would include questions about substance use in their histories. By the mid-2000s, that's changed. So now screening for substance use is considered a critical component of primary care. So that's the good news. This slide shows us the bad news. In 2007, when we surveyed Massachusetts pediatricians, we asked those of them who said they screened how they screened and whether they used a tool, and only about 1/3 of them said that they screened using a validated tool, and that number didn't change much in 2014 in a national sample. Fewer than 1/4 of respondents said that they were using a screening tool. So we tried to understand a little bit why pediatricians were slow to pick up the recommendation to use a validated tool, and we spent some time talking to pediatricians in one-on-one interviews. And here is a sample quote. This is a practicing pediatrician who says, there hasn't been agreement among the physicians in my practice about the need for a screening tool on drug and alcohol use. In other words, the pediatrician was saying that he thought clinical instincts were a good enough way to pick up substance use and associated problems. Unfortunately, the data just doesn't bear that out. This slide is from a publication by one of my colleagues, Celeste Wilson, published back in 2004. And what she showed is that the sensitivity of clinical impressions for picking up substance use is about 63%. So more than half of the time when a child was using alcohol or other substances, the pediatrician was aware just based on clinical instincts. But the sensitivity of clinical instincts for picking up substance use problems or disorders was strikingly low. Only 14% of kids with problems were identified, only 10% of kids with a substance use disorder, and not a single kid with dependence or addiction was picked up. This really underscores the need for a validated tool to help us really understand not just whether a child is using, but where they fall along the spectrum. Here's another quote from a practicing pediatrician who says that he works in a very small city and he wouldn't think that the kids are really using drugs and alcohol. I paused for a minute just to tell you that this particular practitioner was working in New Hampshire, and that happens to be the state with the second highest rate of youth alcohol use in the entire country. But there is a tendency to think that people feel that wherever they're practicing, there's less substance use than in other places. And here's another exemplar quote. We heard that if patients are drinking, it's like stupid high school stuff. Kids go out and have a couple of beers on a weekend here and there. It's not chronic alcohol problems. This really underscores that many of us, when we're doing screening, we think that we're looking for kids with addictions or with severe substance use disorders like this young woman on the left. And we will not pick up many severe substance use disorders using screening. There are other ways that we'll pick that up, and it is true that kids with the most severe disorders will need other ways of finding them and addressing them, because many of them don't come in for regular pediatric primary care. So that's not really who we're looking for. We're really more looking for the kids on the right who are using alcohol, marijuana, and other substances, many of them fairly regularly, but for whom associated problems are subtle and are not going to be picked up by clinical instincts. Really need a tool to suss those out. So a couple of years ago, the group that I work with at Boston Children's Hospital took out the American Academy of Pediatrics recommendations for brief interventions, and we noticed that there were 4 slightly different brief interventions depending on an adolescent's experience with substances, and I've represented them here on this chart, which is also page 9 in the toolkit. You can see that there's one intervention for adolescents who have not started to use, and that's meant to prevent or delay initiation. There's a slightly different recommendation for those who have started to use but haven't developed a substance use disorder. And similarly, there are recommendations for adolescents with mild to moderate substance use disorders and those for severe substance use disorders. And we thought, okay, well, if these are the 4 interventions, wouldn't it be great to have a tool that could tell us which level of experience an adolescent was at? And so we applied to NIDA for funding, and we developed a screening tool. And basically, we would put some questions in, and then we would run it through some computer analysis, and we would generate those 4 levels. And we built the tool. Actually, here is the schematic of how it worked. And when we got our results, we presented it back to NIDA, and we said, we think that this actually works pretty well, and we'd like to recommend this tool for use in pediatric primary care. And the project officer at NIDA, she said to us, well, that's very nice. It's a very nice study, and I think that the tool looks pretty good. But what I'd like you to do is just look at the very first question that you have, and now I've put it up on the screen now. And you can see that the first question is, in the past year, how many times have you used tobacco? And then it's asked separately for alcohol and marijuana. And the adolescent is asked to select one of the choices on the right, never, once or twice, monthly, or weekly. And so a project officer said to us, could you tell me how well the 4 answer choices map on to the substance use levels that you're looking for? And so basically she was asking us to make a map like the one shown on the screen here. And our team thought that that this was kind of a silly request, that it would really clearly take a lot of questions to figure out what level kids' substance use was at, and to pick out kids who had substance use disorders and those with severe disorders was going to need something much more sophisticated than this simple question. But because we were asked to do it, we ran the analysis, and you can probably tell the way this story is going that she was absolutely right. It turns out that those frequency of use question mapped almost perfectly onto the categories that we're looking for, and such that kids who reported that they were using monthly had, with very high sensitivity and specificity, that picked out kids with mild to moderate substance use disorder, and those who said that they were using weekly or more picked out kids with severe substance use disorders. And so we published that in JAMA Pediatrics a couple of years ago, and we thought, wow, that really should be a tool that would be very easy to use in the clinic. So we called the tool S2BI. and that is the tool that the toolkit is based on. There are other tools, and this is a screenshot of page 41 in the toolkit that shows you that there are a number of tools that you can use that accurately pick up substance use problems in adolescents. Many people in the audience may be using the CRAFT, and if that's already built into your EMR, you can certainly continue to use it. The CRAFT has good screen-like properties, but if you're not screening routinely or if you don't have something built into the EMR, you might actually consider instituting the S2BI because it's very quick, it's very efficient, and its psychometric properties look to be really excellent. So here's page 10 of the workbook. This shows us the long form of the screening to brief intervention tool, and you can see you could give this out on a piece of paper. This is the screening questions about tobacco, alcohol, and marijuana. And if an adolescent answers anything other than never to any of the first three questions, we recommend continuing and asking about these other substances to provide more clinical information to facilitate a brief intervention. Based on the S2BI screen, we put together an algorithm, a very quick guide showing what the different recommendations are for each level of substance use. And this you can actually find as a card in the toolkit. So for those of you who have ordered and received the toolkits, you can see the quick guide with the suggestions there. It's a good reminder of what we're doing. And I'm going to take you through those brief interventions now to give you some samples and show you where you can find the vignettes in the toolkit. So starting with non-users, it turns out that for pediatricians and other primary care providers who take care of children, it's very important to give a prevention message for adolescents who are non-users. This is much more important in children than in adults because by adulthood, substance use patterns are pretty stable, and it's unusual for somebody to develop a substance use disorder in adulthood, but that is not at all true of adolescents. So you might screen a 12 or 13-year-old and find that child is abstaining, but that's no guarantee that child will continue to abstain as he gets older. So we recommend giving a prevention message. There's been some research that shows that a prevention message by a pediatrician may actually reduce the initiation of alcohol use in kids. And so these are very simple. Here's an example. So this is a pediatrician who is speaking to a young boy who has not initiated use of alcohol, marijuana, or other substances, and she says, good for you for not using alcohol or other drugs. That's one of the best things you can do to protect your health. And she also adds, and of course most kids your age don't use substances. And so that's a recommendation from the National Institute on Alcohol and Alcohol Abuse and Alcoholism. That's a brief norms correction just to really remind the younger kids that yes, we're doing screening, but that doesn't mean we expect them to be using substances. When you're screening an older teen who is abstinent, you may want to define the abstinence as a choice, since certainly by mid-high school, most kids will have had the opportunity to try alcohol and marijuana, and at that point, abstinence is really a choice. So giving them positive reinforcement about that is the recommendation. For kids who say that they've used a substance once or twice in the past year, we recommend giving cessation advice. Here's an example of that. This is Marcus. He's a 16-year-old boy. He reports marijuana use once or twice in the past year, and his pediatrician says to him, I recommend that you don't use marijuana at all. There's a lot of evidence that shows that marijuana is not good for developing brain. In particular, it can really make it harder for kids to focus, not only at school but also on the football field I know that your team is set to have a great year, and I would hate to see anything interfere with that. There's another sample on page 16 in the toolkit of a pediatrician giving brief advice. For kids who have started using regularly, we recommend what we call a brief motivational intervention. And here really what we're targeting is we're going to hope to get to a spot where we can ask an adolescent to make a behavior change plan or negotiate cutting down or stopping. And of course, when we do that, we want to target the highest risk behaviors. Now on this slide, you'll see a couple of different steps. And so those steps are indicating the process that we're going to take. With the end that we're trying to get to, I have highlighted in red. Okay, so before we can ask for a behavior change, we have to get an adolescent really thinking about their ambivalence or what he or she doesn't like about substance use, to really get them to a place where they might be willing to consider a behavior change. In addition, while we're doing this, it's always a good idea to give clear medical advice and to offer your expertise in how substance use impacts health. So here's an example. This is Katie. She's a 17-year-old girl. She reports monthly alcohol use and once or twice marijuana use. So the next step in the brief intervention after we get the screen result is to do a little assessment to try and figure out if there are any problems associated with substance use. So here, one way of doing that is by using the CRAFT as an assessment guide. And if you're already familiar with the CRAFT, this could be a very good way of quickly identifying problems that can be explored further in a clinical conversation. So in this context, CRAFT is not used as a screen. When we use it as a screen, we're really looking for yes/no answers, and we're counting up the yeses. But here, we're listening for yeses, and then we're further exploring them to really understand better what sorts of problems the adolescent may have had associated with substance use. So in this case, Katie says no to the first 4 CRAFT questions. When we ask her about forget, she says yes, and so the pediatrician says to her, well, tell me more about that. And she says, well, I've certainly forgotten things that happened on a couple of occasions. And she says, really, can you give me an example? And she says, well, I've had a couple of blackouts with drinking, and actually there was this one time where I just woke up in my bed, and actually that was a little bit scary. So spending a little time, not just stopping at the yes, but spending a little time to really understand the context of substance use and the context of the problems that are coming up. Trouble, she also answers yes, and she expands on it. She says that she was suspended for a couple of weeks because she was drunk at the homecoming game, and she threw up in the bathroom. It's funny that we wrote this case a couple of years ago as part of the toolkit, but we had a patient with almost this exact same story walk in about a month ago, and so I can tell you more about the story. Actually, so this young woman got drunk at the homecoming game, and actually her parents were sitting a couple of sections over. So she was caught throwing up in the bathroom. A teacher came in and saw her and actually brought her right to her parents. So of course her parents were aware of the incident, and that's typical that when a kid does have a problem associated with substance use, parents often find out, because that's the first thing, the police, adults, or other parents, that's usually the first people that we'll go to. So after exploring the problems, the pediatrician uses those problems as a pivot point in the conversation. She kind of summarizes, and she says, it really seems that you enjoy drinking at parties, and that's become part of your social life, and at the same time, It's been scary for you a couple of times that you've had blackouts, and certainly you wouldn't want a repeat of the incident that happened at the homecoming game. How do you think you can better protect yourself in the future? And so really the goal is to get Katie thinking about making a behavior change. So here Katie's starting to think, well, you know what, maybe that was too much. Maybe I should do something about this. So pediatrician fills in a little health information. She says, you know, when you have a blackout, that means that you've drunk enough to poison the cells that lay down new memories, at least temporarily. And so she's filling in, this is actually what's happening in your brain. This is why you're experiencing these symptoms. This is what the alcohol is doing. And then the pediatrician gives very clear advice that the best thing to do would be to quit, to not use alcohol. That is the health recommendation. Katie responds that she wouldn't consider quitting. She's not interested in that at all. And so they negotiate around, okay, so if you're not going to quit, I think cutting down is a good idea. Remember that not all kids that we talk to are going to be willing to quit. And our goal is to make a behavior change. So if they're not willing to quit, cutting down, stopping for a while, taking a break, or not engaging in the highest risk behaviors, any of this is movement in the right direction. This is a change plan, and this is actually a screenshot of page 19 in the workbook, where we've recorded Katie's S2BI screen results, right? You can see that she reports monthly use of alcohol, no use of the other substances, and she negotiates a plan with her doctor. She's going to limit herself to drinking no more than 2 drinks a night, and she's never going to drive after drinking or ride with an impaired driver. The doctor offers her the opportunity to speak with the behavioral health counselor in the office, and she says she's not interested in an alcohol counseling session at this time. So she puts in there, notice that in the green bar across the top, the doctor puts her recommendation. My doctor recommends that I stop, but for now I will. And then she puts in Katie's recommendation. And she also asks Katie to come back for a follow-up in 1 month. And we recommend that whenever an adolescent has agreed to make a behavior change plan, that they should be followed up just to see how it went. Were they able to stick to it? Have they had more problems? Are they interested in making further changes? And so here's a screenshot of page 18 in the toolkit, and it is a scenario with a 16-year-old boy who is also using alcohol monthly, and how things progress with him. Finally, we're going to an example of referral to treatment. So for kids who are using weekly or more on the S2BI tool, they're very likely to have a severe substance use disorder. This could, and the recommendation for these kids is to refer to the appropriate level of care. Now, regardless of which tool you're using, anybody who's identified with a severe substance use disorder should be, the recommendation is a referral. Again, the black lettered rows are showing us the process of how we get to referring somebody to the level of referring somebody to a higher level of care. But the end point that we're looking for is highlighted there in red. You may notice that the steps, the process of referral to treatment are actually very, very similar to brief intervention. We're going to do the same, have the same kind of conversation. So this is Alex. He's a 15-year-old boy who reports weekly marijuana use. We do a craft screen with him. Actually, I'm sorry, we do an assessment with him that's based on the craft. He says that, yes, he uses marijuana to relax when he feels stressed. He talks about it. He says that he often has these arguments with his mom and he gets really angry, and so what he does is he goes out into the woods and he smokes. He says that he often smokes alone. When he's asked about whether his family is concerned, he says, yes, his mother is constantly on his case, but she just doesn't understand. She's from a different generation. She doesn't really understand that these days marijuana is really medicine. And when talking about trouble, he says that he was brought home by the police a couple of times because he was caught in the woods. Pediatrician asks him how he's doing at school, and he says that actually, yes, his grades have dropped, although he doesn't think that that's related to his marijuana use at all. So the doctor decides to explore more about what is happening at school. Why do you think your grades have dropped? And so he says that, well, yes, his grades have dropped, but it has really nothing to do with marijuana use. This is actually a picture of his math teacher, and it's very hard to work with a teacher like this. She's very, very strict, and he thinks that she just doesn't like him. So the pediatrician gives him brief advice, and she actually starts by saying, it really does sound like there's a lot going on for you at school. This is a very busy year at school. It does sound like you have a very tough math teacher, and that can make things harder. But she also says that it's also true that kids who smoke marijuana tend to have more problems at school. It's not unusual for kids to have a drop in their grades once they start using marijuana regularly. And she says there's lots of evidence that marijuana can interfere with brain development. And she says that, for your health, I recommend that you quit. And the first thing he thinks is, well, I could never quit because there's just too much stress. I don't really know how to manage stress without marijuana. And so this is a really critical point in their conversation, because at this point, sending Alex to a counselor or higher level of care to address his marijuana use is not likely something that he'll follow through on, because in fact doesn't really find his substance use bothersome. It's not a problem for him, and so he has no reason to want to change it. But the stress is a problem for him. He's unhappy about it, and marijuana right now is his only tool for managing it. So his clinician picks up on that, and she says, that's managing stress can be really challenging. I would like you to see a counselor who could help you with stress in addition to discussing marijuana use. And so that is actually something that's much more interesting to him. If the focus of this is really going to be on stress reduction, then that might be something that he's more interested in doing. Now, still in all, it's very hard for an adolescent to actually follow through on a referral on their own, even if they're interested in going. And so the pediatrician asks, can we bring your mom in? And of course, the first thing Alex thinks about is, oh, no, I mean, my mom and I only argue about marijuana. This is a very bad topic for us. I just don't want to have this conversation with her. And so pediatrician says, well, I could tell your mom that we've had a really honest conversation, that you're willing to think about this a little bit more, and that you've agreed to meet with a counselor. And while I don't know what your mom is going to say, many of the parents that I've worked with in this situation have really been happy that there's been some progress. And so Alex thinks, well, okay, if you can present it that way, maybe that would be okay. And I think it's very important. It's a very reasonable thing to do to invite a parent in, particularly when the parent already knows about the problem. In fact, there's not really an issue of confidentiality here, because mother's already very well aware, and in fact, it's a source of stress between the two of them. So inviting to bring her in so that you can help reduce the stress, help bring the two of them together and move the whole system forward is something that can be skillfully done and can be a benefit to everybody. And without this piece, it's extremely unlikely that any kind of referral will be followed through on. Now, I just want to switch gears for just a moment. So once you've decided that you're going to send somebody for a higher level of care, what exactly does that mean? Well, often we think, oh, well, that means I need to send somebody to a rehab program, and we all know there aren't that many rehab programs in my area that I can send them to. So that's a real problem. Well, it turns out that for substance use disorders, just like for every other condition, we always want to refer kids to the least restrictive level of care. And for the majority of kids that we're going to be seeing in primary care, those are going to be outpatient programs, and often they might just be mental health counselors or addiction counselors in the community. For some kids, particularly if you're seeing kids who have opioid use disorders, which is unfortunately become more and more common in the Commonwealth, you may want to refer them to a provider who can prescribe buprenorphine or naltrexone or other medications used to treat opioid use disorders. This is a very busy slide. It's page 52 in the workbook, and really it's a flow chart that gives you thoughts about the recommended level of care. So you just follow the questions down, and it will give you some advice on guidance about how to make that referral and where you're going. And there's also a point we give advice on when to call the hotline to get specific recommendations on specific providers and programs in your area. And page 27 in the toolkit is a sample scenario number 3. It's the story of a young boy who has substance use disorder who needs a referral to treatment. Finally, I just want to show everybody the URL where you can download the toolkit for providers. And I think that we can stop there and take questions.
Hi, so I'm just going to unmute your phones, and while I do that, if you could put your phone on mute if you're not talking, that would be great, so that we don't get a lot of background noise. I'm trying to figure out how to do this. While we're unmuting the phones, I want to acknowledge that the toolkit, the SBIRT toolkit with the S2BI screening tool, was written by Dr. Levy, and it was really put together in collaboration with the Department of Public Health Bureau of Substance Abuse Services, with the Department of Mental Health, and our folks here at MCPAP. And we want to thank everybody for their contributions. The toolkit, we're going to leave this slide up so that you can write down where to get the toolkit. The toolkit includes the quick guide, which Dr. Levy referenced, a postcard that has the S2BI screen on it, and the workbook. The workbook, we've been told, can look kind of daunting, but it's very digestible in terms of having the case scenarios and the flow charts and the role plays at the end, which we encourage people to take a look at and use to practice your brief interventions.
I can click to unmute.
Yeah, where?
You have to do it individual.
No.
Can't you just be able to type questions?
Okay, so we're going to take a look at the questions, and let's just see what we have here. So, ooh, lots of questions. Okay. The first question is, do you give adolescents a written behavioral health plan? If so, and if adolescents don't want parents to see what methods you have used to give a written plan to them? What do you say if they don't want parents to know about why they are coming back for a follow-up visit?
It sounds like two questions.
Two questions, sorry.
Rolled into one. So the first question is, do we give all adolescents a behavioral health plan? And I would say that's up to each practitioner and each practice, and then beyond that, the adolescents themselves. So we've shown you a sample of how you could make a written behavioral change plan. This is something simple and it's useful. So we recommend that you do it. Of course, if an adolescent doesn't want to take it, then they don't have to take it. And if you are doing this completely confidentially and you're convinced that the parents don't know any of this, then I would certainly advise the adolescent to be very careful what they do with the change plan if they don't want their parents to know or to be involved. I think the second question was, if I'm recommending that all adolescents come back to follow up on the change plan, how do I bring them back? And that's one of the trickiest questions that we get asked every time we make this presentation. So so just like it's hard to get an adolescent patient to complete a referral, it's hard to get them to come back without their parents' knowledge, and it might be impossible if an explanation of benefits is going to go back to the parents. It might be absolutely impossible to complete a visit without that. So what we've heard other audience members share is that you can inform the parents that you'd like to see the child back, but without giving a very specific reason, saying we didn't finish. There are a couple of things that I would like to follow up on. I think that works for some people. In the toolkit, I think the advice is that, if you can, have the child come back in a month, and if you can't have them come back specifically for follow-up, make sure that you put a very good note in your medical record so that the next time the child comes in for any reason, you'll be able to do that follow-up. And if other audience members have other things they want to share, we're having some difficulty getting the lines unmuted, but if anybody wants to type in another idea, we'd be happy to keep an eye out for that and read it out to the rest of the audience.
It looks like Robin Smith has a question. Robin, do you want to ask your question?
No, I already asked it. I don't know if somehow I'm getting unmuted, so thank you.
Okay, thank you. If anybody has a question, you can click the raise your hand button and I can unmute you individually. In the meantime, we'll look at some more questions. So the next written question is, how do you balance the need for confidentiality with the desire for follow-up? If you aren't given permission to talk with the parents, how do you explain to parents the need for follow-up? Similar to the other question.
Yeah, I think that it's, the balance for confidentiality is always tricky. The first thing to do is always to ask the adolescent for permission. If you've decided that you are not going to break confidentiality, if the risk isn't really acute enough, it's still a good idea to ask the adolescent if you can invite parents in. And if parents are already aware of the problems, and usually by the time you're negotiating a change plan, there have been problems and parents are already aware, then talking to the adolescent about how you think you can make this a positive experience might be really helpful.
Okay, the next question is, can you review the frequency of administering the SBIRT and who in the team does which part? Medical assistant, provider, integrated behavioral health provider. Also, the amount of time in a high-risk Dorchester practice.
So I think a lot of these questions are, I really appreciate them, and I think that that there's not necessarily one model. There's not one size that fits all. We do recommend that the easiest implementation is to have the adolescent fill out the S2BI either on paper or by clinical interview by the clinical assistant who's doing the height and weight and blood pressure. Or if you have the option of doing it on an iPad, I think that is even the best way of administering the S2BI before the patient comes in. to speak with their primary care provider, and that's just an efficiency. It's a good use of time, and it's generally a good time to ask questions. There's many offices have told us ways in which they've created little confidential workspaces where this can be done. I would say that the brief interventions, so whether we're giving a prevention message or a cessation message, or trying to encourage a kid to make a behavior change plan, or making the recommendation for a higher level of care, that's really, I would say, the role of the primary care provider. Although some practices may want to hand off quickly to a behavioral health counselor if there's one in the clinic already. Anytime that there's regular use identified, those kids could automatically get a warm handoff to a behavioral health counselor. I think that would really depend on how the office is set up.
Do you want to comment on the high-risk practice?
So, I think, interestingly that, all practices that see adolescents are high risk. Was there a specific question about a high-risk practice?
How much time would it take?
Oh, how much time? I think that the screen itself is a trivial amount of time and can be done even before the time with the provider. It's really the issue of brief intervention. Now, clearly, prevention messages and cessation messages are very quick. They can be seconds long. The other two interventions, where there's a real conversation and negotiation, are a bit longer. I think they can be done fairly quickly in about 5 minutes, or between 5 and 10 minutes. And I like to think about it the same way. I would think about a kid who comes in and says they're having headaches, right? So, it might take 5 or even 10 minutes to really try and get a good history and understand what the source of the headaches is, and whether the child needs a referral for further evaluation or can be managed at home, or with other strategies. So I think that they're fairly equivalent, and I think that practices have ways for accommodating those kinds of interventions in primary care. But again, people asking the questions really have the best answers to them, and I think at the end of the day, every office might do this a little bit differently, and I do think that MCPAP gives a little support on helping people to implement specifically in their office.
Thank you. The next question asks, I am embedded in pediatrics as a social worker. Is this toolkit designed for social workers to use?
So I would be delighted if social workers would use the toolkit. I think that if you're embedded in a primary care office, I would like to see the entire office practicing as a team, and although the roles might be split up, I think it would be terrific for everybody to use the toolkit and really understand what's in there. So if you're an embedded behavioral health specialist, it could be that anytime regular substance use, meaning monthly or more, is identified, that you would do the brief interventions. But again, I think that that's a decision that's made at the individual practice level, but that's certainly a very reasonable approach.
Thank you. The next question is, do you have an electronic customizable behavioral health plan in the work, such as the sample in the workbook for EMR?
So the sample in the workbook is a PDF version. You can see that it's very, very simple, so I don't think that it would be difficult to recreate, but we did not make it as an electronic version.
Okay. How would the PCP handle a situation in which the adolescent chooses not to share any information with their guardian, but they are in DCF custody?
Ooh. So I think that that's a complicated question, and it really depends on what the issues are. So if anytime that an adolescent is at risk of acute danger for harming themselves or others, I think that confidentiality really cannot be maintained. And so, there's a brief section in the toolkit on advice on confidentiality. And one of the recommendations is that for all adolescent patients, and many folks probably do this already, is giving them an overview at the adolescent visit of what the confidentiality policy is and what can and can't be kept confidential. Certainly, any issue that any situation that's putting an adolescent at acute risk should not be maintained confidential. Now, really, the problem with substance use is determining what is an acute risk. So typically, we say that for older adolescents, occasional alcohol or marijuana use probably doesn't need to be disclosed. It's probably not imminent enough risk to be disclosed. But for a very young adolescent, for a 12-year-old who's been drinking, you might decide that that is an acute risk. For an older adolescent who's driving while impaired, even if the use is only occasional, but you're getting reports that sometimes kids will tell us that they feel like they drive better after they've smoked marijuana, and if you're getting those reports that without being able to negotiate a behavior change really convincingly, you might decide that that is an acute risk. I mean, likewise, if you have a patient with diabetes or a chronic medical condition who's using substances only occasionally but is non-adherent with their medications or forgetting to take their medications when they do, that might be an acute risk too. So it really is a matter of clinical judgment, and it really is, it really depends on us getting the story and understanding it.
Hi, I see that Michelle Dalal has a question. Michelle, I'm going to unmute your phone. Would you like to ask your question?
Yeah, I was just wondering if S2BI is an approved screening tool by MassHealth. I don't remember seeing it on their list.
Marcy's going to answer that question.
Hi. Yeah, so this is a common question that we get, and right now it is not an approved screening tool, like the CRAFT is. We are going to be having some conversations with MassHealth. We don't know what's going to happen with that. However, what we want to point out is that the S2BI is really a very brief screening tool, and it's really very quick. You can tack it on to the end of your usual behavioral health screening tool. And, it's when you get into the brief interventions, obviously, as Dr. Levy mentioned, particularly the sort of higher level issues that you end up spending a lot of time. Stay tuned for more information on that. But it's a pretty quick and easy thing to do, even though you're not getting paid for it.
If you do decide to use the S2BI universally, and then for kids who report use, you're actually administering the CRAFT, just because you've done an S2BI screen, it doesn't preclude you from using the CRAFT in the way that was demonstrated as an assessment guide. And in fact, the CRAFT is not recommended for kids who don't use, right? Those kids are screened out and never given the CRAFT anyway. So it's not all that different from what people might be doing now.
Sharon, could you talk a little bit about what ages you should start screening, perhaps, and what ages this tool is good for?
So the tool was validated for kids aged 12 to 17. The American Academy of Pediatrics recommends starting screening at age 12, but not before the first time that you see the adolescent without a parent present. So if your office doesn't start that until they're 13, then hold off until you have a chance to have a confidential conversation with them. I think the average nationally when we asked pediatricians was about 12.
Thank you. Another question came in. Has anyone used the toolkit in school prevention programs?
That's a very good question. There are a couple of districts that are doing universal screening and brief intervention. I don't know offhand what tools they're using. I don't know if the person who asked the question is aware of the pending legislation that will mandate schools to offer screening and brief intervention to middle schoolers and high schoolers in all public schools across the Commonwealth. If that goes through, I certainly hope that that people take a look at S2BI as the screening tool.
Thank you. I want to close up by mentioning that in addition to the items that I already mentioned in the toolkit, there are a variety of pamphlets that you can use to hand out to kids and their parents, and they are available for free also at the DPH Mass Clearinghouse website. And also that if you would like or missed part of this, you can certainly contact your MCPAP hub to get a training on site at your practice. The Massburg Training and Technical Assistance Center also provides training on this screening tool. And if you're interested in that, just contact your MCPAP hub, or if you are not a MCPAP enrolled provider, you can certainly email us here at MCPAP, and that email is MCPAP MCPAP@valueoptions.com. I want to thank everybody for joining us today and remind you you're going to get a survey. We hope you'll fill that out. It shouldn't take more than 2 minutes, and that we'll be having these clinical conversations ongoing on a monthly basis, the 4th Tuesday of each month from 12:15 to 1:15. And our next clinical conversation will be focused on managing challenging behaviors with young children, and we're going to be talking about the PPP Positive Parenting Program on that webinar. Thank you very much for joining us.